I'd like to start first of all by acknowledging the traditional owners of the lands on which we're meeting, and I'm on the lands of the Wurundjeri people of the Kulin Nation here in Melbourne, and pay my respect to elders past, present and emerging, and also welcome any Indigenous people that are on the call today. So pretty much where are we with HIV cure in 2025 is what I want to talk about to this audience. And even though we have fantastic antiviral therapy and now injectable antiviral therapy every 2 months, maybe soon every 6 months, I think we know that we still need a cure. Many reasons why. ART still has toxicity. ART has not available to everyone. We in Australia, of course, the situation is very, very different. There's still obviously stigma associated with HIV, and ART costs money. And again, in a country like Australia, access and cost isn't something we think about a lot, but globally it is an important issue, and it has become an even more important issue with recent changes in the US administration. And we all want 95% of people living with HIV to ultimately have access to treatment, but that's going to cost $29 to $30 billion a year. And here we are seeing PEPFAR dismantled and a very uncertain future for people with HIV, particularly in low middle income countries who are dependent on PEPFAR and the Global Fund. So for me, that's very much a reminder of why we need a cure. But there's also a public health argument for why we need a cure. And that is because there are unmet needs currently with ART. Not everyone does well on ART for multiple reasons. And so there still is a need for public health reasons, even though we have good prevention and treatment modalities, for a safe, affordable, scalable, effective cure for people not doing well on ART for any reason, and ideally to prevent reinfection. And the ideal cure is one that would be truly transformative. There's strategies that need to be given over a brief period of time. So, of course, a cure is not a BNAB, a broadly neutralizing antibody, or long-acting ART that's injected even once a year. A cure we think about as over a brief period of time. It might be 6 months, it might be one-shot cure, very unlikely at the moment, but that means, and after that you just have ongoing monitoring. So first of all, is a cure possible? Well, you've all heard about stem cell transplants, but this is where we are right now. We have 9 people that have been cured of HIV following a stem cell transplant. I think when you scan across these reports, starting from Timothy Brown in 2009 to a Norwegian patient described in 2025 earlier this year, they are largely men. There's one woman in amongst this group, which is the New York patient. They are largely from high-income countries, all from high-income countries, I should say, living in North America or Europe. And they're not all, so you will know that Timothy Brown and maybe the London patient, Adam Castelleo, received a bone marrow from a donor who was naturally resistant to HIV, meaning that the donor was CCR5 negative, lacked the receptor that HIV needs to enter a cell. But what's been really interesting about these 9 people is that not every one of them received a donor from a CCR5 negative person. So if you don't have CCR5, we call you homozygous. If you have one copy of CCR5 and one not, you're heterozygous, or you actually express CCR5, meaning that you're what we call wild type. And the Geneva patient received from a donor that was wild type. And then more recently, the next Berlin patient received a donation that was heterozygous. So what this means is that CCR5 is not the whole story. Stem cell transplants also seem to be able to attack and eliminate the reservoir. But of course, this is not a pathway to cure because way too toxic, way too complicated, and a high mortality. And the only reason that people receive these transplants is because they had a life-threatening cancer, in most cases, a leukemia. But there are other pathways to a cure, and this is something that we now think of or talk about as natural cures, or what many of you will have heard of elite control, so people that can naturally control their virus to levels less than 50 copies per mil. But there's a subgroup of elite controllers that are now called exceptional elite controllers, and that is people that you actually can't find any remnants of you can find remnants, but you can't find intact virus inside cells. And inside cells, we measure HIV DNA as opposed to the usual viral load assay, HIV RNA. So this phenomenon was first described in 2012 in the US, was then discussed and described in great detail in 2020, a woman by the name of Lorene Willenberg. And Lorene has had HIV for over 30 years, never been on ART, has fragments of the virus in her blood, but no full-length, what we call full-length intact virus. Interestingly, there was an update on Lorene Willenberg at the Kigali conference. She unfortunately has lung cancer and therefore received intensive chemotherapy and did not go on ART during her chemotherapy, and still never had virus rebound. So the thinking is she is truly cured, and she did it on her own, meaning never had any kind of intervention. And there's also another woman from Argentina that has also seems to have experienced exceptional elite control, and 4 other similar cases. So this now is rare, no intervention. But clearly some people are able to completely clear out intact virus. So lots of work being done to understand why. And the clue is, we think, that the virus is in a part of the DNA where it's very difficult to wake it up. And for some reason, these participants can get rid of the virus that can easily rebound, but these other bits of the virus stay around. We also know that some people, another form of natural cure, can control virus after a short period on antiretroviral therapy. And these people are called post-treatment controllers. The treatment here is ART. And it was first described in France in a cohort of people who had started ART during acute infection, and then after 3 years on ART stopped antiretroviral therapy and virus didn't come back up. Recently, a very nice big study that looked at 24 studies of people who stopped antiviral therapy, involving over 380 participants. And if you were treated during acute infection, 6% of people could control virus to less than 50 copies per mil. And only 1% could do that if they were treated during chronic infection. So this tells us that that a small group of people are able to control virus after they've had a period on ART. It's very rare if you were treated during chronic infection. It's still pretty rare if you're treated during acute infection, but probably about 6% of people can do it. So if you think about, there's different paths to what we now call, rather than remission, ART-free viral control. This is what plasma viral load looks like for an elite controller. They never have viral replication, and less than 1% of people around the world can control their virus with no intervention. And a smaller component of them are exceptional elite controllers where there's no intact virus detectable. About 4% of people control after a small period on ART, still not very common. And what we're in the era of cure, we're more interested in what interventions can lead to ART-free viral control. So these are people that are on ART, have a period, some kind of intervention. I'll talk about what those interventions might be, and then stop ART and have a small period of viral replication. And this is maybe more common than we thought, and that's what we talk about for cures interventions. So I'll talk a little bit about what interventions what clinical trials are telling us that will work in a subset of people. So what are some of the strategies? What are the strategies to achieve a cure? First of all, what's the goal? Well, here's the problem. These are a little schematic of cells in the body that contain a small bit, that contain virus. So this is the latent reservoir. Very few cells, 1 in a million cells in people on antiviral therapy carry a latent virus. Now, if we could get rid of every one of those cells, like was done in stem cell transplants, this is really a true cure, or what we talk about as eradication. The other possibility is that we reduce the pool of infected cells and increase the immune defense to allow for remission or ART-free viral control. And it's really these interventions that are getting a lot of interest at the moment. And actually, if you look at immune-mediated or immunotherapy, this is all the different things that are currently being tested in clinical trials around the world. I won't go into all of them, but there's a lot of excitement about broadly neutralizing antibodies and a bit of excitement about immune checkpoint blockade. And I'll just tell you a bit about that. So what's a broadly neutralizing antibody? Well, some people, everyone with HIV makes antibodies because that's what you measure in an HIV test. When someone says, I'm HIV positive, it means that the test picked up an antibody, which means that the body is making a response to the virus. But most people make pretty poor antibodies that don't help them control the virus. But some people make really good antibodies, and we call them broadly neutralizing antibodies. They're like superpowered antibodies that can bind and get rid of a whole range of viruses. And we can make those antibodies. We can manufacture them synthetically, essentially. And there's lots of them around. Many have been identified. And they're being tested for prevention. They don't work so well for prevention. For treatment, they look quite good. So the people in Kigali, there was a study of 6 monthly treatment, lenacapavir, and antibodies every 6 months. And they're also being used for cure. And they're being used for cure because these antibodies can probably target and kill an infected cell, and they can also boost immune responses. So this is just a summary of 6 studies that have been reported recently, either published or presented, of antibodies. And the antibodies are given at the time of people interrupting treatment. So virus is coming back and you've got the antibody on board. And what you can see, and in these blue boxes, are the numbers of participants in the study. So they're really small studies, 11 people, 9 people, 12 people. And the other number is the number of people that met the endpoint, so they could control virus, which isn't less than 50 copies per mil. It was 2,000 copies per mil or lower for many months. And you can see there are a few participants that can do this. And more recently, another study, Rio, which was actually a big study, had close to 80 people in it, about 50% control. And this other study, first study in Africa, about 40% control. So we're seeing control in a subset of people that receive these antibodies. We don't know why some people respond better than others, and we're still working out how to find those people, because those people potentially could potentially safely go off treatment. It's a very active area of research. The other area of research is something called anti-PD-1, and that is it's an immunotherapy that comes from the cancer world, revolutionized treatment of cancer. And what PD-1 does is it beefs up your immune response against something foreign. So in cancer, it beefs up your immune response against cancer, but it does the same in laboratory models against HIV. We've studied it in people that have cancer, but this is the first trial done by AbbVie in people with HIV without cancer. They used a type of anti-PD-1 and then stopped ART. And you can see in the placebo arm, everyone rebounds quite quickly. But in the anti-PD-1 arm, you've got a few participants here, case 1 and case 2, who grumble at this low level of virus for many, many weeks after stopping ART. So they've achieved ART-free viral control, and 3 people here shown in purple that have had partial control. So anti-PD-1 also seems to induce control in some people, and we're actually doing a study of anti-PD-1 currently in Melbourne and in Singapore. Gene therapy is another area that people are quite excited about. Gene therapy essentially means targeting the genes in some way, and you can target the genes, what we call with what looks like gene scissors, to boost the immune response or attack, to protect, so you engineer cells to be resistant to HIV, or to purge, to directly eliminate the virus. And this can be done either ex vivo, outside the body, or in vivo, inside the body. And these clinical trials are happening. There's several clinical trials that modify the cells outside the body by eliminating the receptor for HIV, CCR5. And there's gene therapy that's happening inside the body where you can inject the gene therapy. Here, the gene scissors are packaged up in another virus called AAV, and you can actually inject the gene that makes a broadly neutralizing antibody so that the person makes their own antibodies. You don't have to give them the antibody. And there's also gene therapy studies that target the virus itself to see if you could actually eliminate the virus itself. This was first done in monkeys. It's recently been done in people. 6 people enrolled in this study. It was safe, but when they stopped ART, the virus rebounded. And the problem is you probably can't get to every virus. In the last few minutes, I'll just quickly tell you about latency reversal. You may have heard of latency reversal. The idea here is to wake up the virus so it then becomes visible to the immune system with something called a latency reversing agent, and then that cell dies. And we've never had really very good latency reversing agents, but recently my team have been using mRNA to reverse latency. I won't get into all the details. It's delivered by a fat bubble, or what we call a lipid nanoparticle, and we can deliver different latency reversing agents. I won't get too much in the details, but this was almost 100-fold more potent than any other latency reversing agent. This is in test tube models. And it actually got a lot of coverage. You may have read about it. I'm happy to talk about it. It's only in test tube models. We haven't put it in animal models, but it's an exciting advance using mRNA for a treatment, not for a vaccine. So just quickly, this is where we are right now in HIV treatment. We have ART, we have long-acting ART. We may soon have broadly neutralizing antibodies that could be given 6 monthly. So treatment is great. And getting better. But what might we have? When might we have a cure? We don't know. Looking like we can get remission with antibodies or anti-PD-1 or what's called immunotherapy, and that might be in a subset of people. We're seeing trials now of gene and cellular therapy that I mentioned, and both ex vivo and in vivo, meaning outside the body or inside the body. And the ultimate goal is a single shot cure, but we're still a way off that. But lots happening in the area, and I'll stop there, and hopefully haven't overloaded you with too much information, and happy to take any questions.